Hi, welcome to UOA On Demand. Tonight's topic is on patellar tendinopathy, otherwise known as jumper's knee. My name is Cris Beiro, and I'm an orthopedic surgeon specializing in sports medicine with University Orthopaedic Associates. I'm joined tonight by my esteemed colleagues and fellow orthopedic surgeons and sports medicine specialists, Dr. Charles Gatt and Dr. Jeffrey Bechler. All right, so I guess we'll jump right into it. What exactly is jumper's knee? And obviously it happens in the knee, but where exactly does it happen? Dr. Bechler, I'll start with you.
Well, so the jumper's knee term is a term that we use loosely to define patellar tendonitis, which is an inflammation of the patella tendon. And if you look on the knee model here that I have, you have your patella, which is here, and you have your thigh bone and your tibia or shin bone. And the patella tendon is the structure that connects your patella to your shin bone or your tibia. And the jumper's knee is a inflammatory condition of the tendon that spans the bone, the tendon that spans the area from the shin bone to the patella. And it usually occurs right at the insertion or right near the insertion of the patella tendon to the patella, right here on the inferior or distal pole of the patella.
That's a very good and detailed explanation. Dr. Gatt, is it a common kind of injury or a common kind of condition? How does this happen and what causes it?
It's a pretty common condition, and we see it in more of an overuse type injury. So it's not really an acute injury. We see it in people that do a lot of explosive work. That's why it's called jumper's knee. You know, we see it in runners, jumpers, basketball players is really common. And, but they essentially, they'll start off with just a little bit of aching pain at the very bottom of their kneecap. It usually bothers them at the end of practice. They don't think much about it, and then they keep on playing through it. And as time goes on, it actually gets, worse and worse to the point where it actually might affect their performance. Maybe they can't run as fast or jump as high, or as the pain's too bad for them to perform. And then it can really reach stages where it hurts just walking around. So again, it's not an acute injury, but they notice it and it gets progressively worse.
Absolutely, I agree. More of a chronic overuse type injury. We see it with jumping sports, as you mentioned, basketball, volleyball, any kind of sports that allow you to push off. And even in sports like soccer, where there's not as much jumping, but you're still pushing off. Dr. Bechler, I was wondering, how do these patients present? When they come into your office, what do you normally see?
So they typically, they're a athlete or a weekend warrior, but somebody who runs and jumps on a significant amount of time when they do their workouts and when they do their exercising. So for the non-athlete, the recreational weekend warrior, we see someone who plays a lot of basketball or who maybe runs a lot, train for marathons, things like that. So it's typically an overuse picture for them in that regard. And then we see it a lot in the high school, junior high, and college athlete for the athletes who are participating most of the year, like year-round sports, or maybe doubling up if they're a junior high or high school student and they're playing a soccer practice, a lacrosse practice, and then 4 games on the weekend, and then their kneecap starts to hurt. So they present with pain in the front of their knee after particularly long periods of running and working out. It usually is not disabling when they first present. It's usually just discomfort, soreness, and an achiness that comes on, when they're done playing is usually how it starts to present.
Absolutely. And just going into, I guess, what you would see on clinical exam, Dr. Gatt, can you tell us what these patients would show you when you examine them?
So first, when I take a history, like one of the first things I ask people to do is I say, point with one finger to where it hurts the most. And they always tend to point, right at the bottom of their kneecap. There's occasional cases, it's not as common, but sometimes they'll point further down the patellar tendon to where it attaches onto the shin bone. That's called the tibial tubercle. And you do see cases like that, not as common, but it certainly exists. So again, the most common case is right at the bottom of the patella, and they say it hurts right here. It generally, to them, feels like a burning type of pain. It hurts them when they push off. So if they're jumping, I'll even say, does it hurt going up and down the stairs? Or does it hurt, when you get up out of a seat? When they're exercising, did it hurt doing squats? and leg presses and things like that. And they'll point to that one spot. I always ask them if they have feelings of instability. Does their knee give way, or does it feel like it's going to give out? And it's not that they have a loose or unstable knee. It's just that sometimes the pain is significant enough that their their quadriceps muscles kind of reflexively shut off, and they feel like their knee might give out. So that's from a history standpoint. When I examine them, there's really generally no swelling. Every now and then you'll see a little localized swelling, but generally their knee looks essentially normal. The whole examination of the knee is normal, except for when I press on the area where they hurt. And if I put my thumb pressed pretty firmly at the bottom of the kneecap, they say that's a spot that hurts. And I do try to localize the area because it's generally not across the entire patellar tendon insertion, but it tends to be at maybe in the central 1/3, or maybe in the inner 1/3 or the outer 1/3. And I do try to localize that because it may have it'll have some impact on how I manage it. So there's that. And then I ask them to, straighten out their knee against resistance. What I find interesting is that if their knee's hanging over the table at 90 degrees, and I say, kick your leg out straight, and I resist it, they have some pain, but they always have more pain when I say, hold your leg out straight. So their leg is perfectly straight. And I say, hold it straight while I push down, and they have even more pain. And I find that as like a very classic finding, which is interesting to me because the tendon isn't stretched as much, but it definitely hurts more when their knee's straight. So all those things, I'm pretty sure they're dealing with patellar tendonitis.
I agree. Definitely that localized pain that you'll see at the bottom of the kneecap or even at the top of the patellar tendon. We always see that. That's classic, as well as some of the other findings you mentioned, things like quadriceps atrophy, and even some loss of flexibility of their hamstrings or quadriceps. Dr. Bechler, can you tell us what other objective studies you would get on these patients? So when they walk into your office, obviously you're examining them, you're taking a very thorough history. What else do we do to kind of diagnose these conditions?
So from a diagnostic standpoint, after the physical examination, we always shoot an X-ray in the office to make sure there is no other source of the reason for their discomfort and the finding. Typically with patellar tendonitis, as you know, the radiograph or the X-ray is negative, it's normal. So occasionally in someone who's had it for a long period of time, you may see a little bone spur or a little calcium deposit in the area, but that's for someone who's had it chronically for a significant, period of time, months to years. The new presentation has a normal X-ray. So that doesn't help with your diagnosis. The diagnosis, as Dr. Gatt pointed out, is 90% history and 10% examination right on the end of the kneecap.
Absolutely.
And then after that, if somebody's going to have further testing for whatever reason, the next test to obtain would be an MRI scan of the knee. Typically, I don't send somebody for an MRI scan of the knee initially for patellar tendonitis or jumper's knee. That would be something that we did down the road if they were somewhat not making progress with the plan that we had designed for them for recovery.
Absolutely. And Dr. Gatt, I guess moving off of what Dr. Bechler said, how would you initially treat these patients before we obtain a MRI? What would you do?
A lot of it depends on the severity of their symptoms and the impact that their symptoms have on their performance. So, if it's a weekend warrior, who's just having a little trouble playing tennis or soccer or something like that, pretty conservative treatment. I'll demonstrate some stretching exercises in the office, show them how to stretch their quadriceps, which is pretty simple. They just kind of, grab their foot and pull their heel to their backside, and it kind of stretches out their quadriceps muscle. I'll have them do some straight leg raises just because there tends to be a little bit of quadriceps inhibition. So by lying on their back and lifting their legs straight into there, I get their quad firing again. But probably the most important thing I tell them to do is ice massage. So, and I always tell them, don't just lay ice on your knee and watch TV, but instead take an ice pack or an ice cube, or actually, I'll tell them to, because a patient told me this, take a small Poland Spring bottle, put some water in it and freeze it. And then you can hold it by the cap and actually massage the soft tissues, like literally rub it with ice, and try to do that for, 15 minutes, twice a day. And ice, being nature's anti-inflammatory, can be really helpful. I mean, they can take, over-the-counter anti-inflammatories like ibuprofen or naproxen, and those things help. And I think, and then maybe a little bit of relative rest. But again, If it's not so bad, the stretching and the ice massage tend to help a lot. Sometimes in the more severe cases, then we start to give them some relative rest. So you might have to cut back on the amount of running you do for a little while, or the amount of time in participation. But I find a lot of people come early enough that a stretching and ice massage and over-the-counter meds work pretty well.
I like that water bottle tip. I'm going to have to use that. That's pretty good. Dr. Bechler, what other treatment modalities do you use for your protocol?
So if the patient is younger, and I think they need a captain of their ship, I send them to organized physical therapy with either a therapist that they can work one-on-one with for a while, so that they can not only get over the episode that they're having now, but get some exercises to try to keep it away in the future. Because once you've developed this and you've had it for a while, it doesn't go away in a couple of days or weeks. It's more months down the road until things quiet down. And it's not unusual for it to come back, because we don't preclude the athlete from participation. We educate them, and they're certainly allowed to participate with the discomfort. They just need to understand the things that are going to make it worse and maybe limit their participation versus the things that will make it better and make it so their participation is more pain-free. So I think enrolling a physical therapy program for the younger patient is a good thing, because it takes the captain of the ship out of the house. Mom and dad don't have to do it. And we don't have to make a 15-year-old adolescent kid be the captain of their ship. They go to physical therapy and they learn the stuff there outside the house.
Absolutely. Dr. Gatt, Dr. Bechler earlier mentioned about potentially getting an MRI. Let's say some of these patients aren't getting better. They've done physical therapy, tried anti-inflammatories, tried some home modalities, and they're just not improving. When we get an MRI to kind of help with what the integrity of the tendon looks like, what would we normally see?
So on a typical MRI, tendons tend to look very black on the MRI. So you'll see the patellar tendon going to the bottom of the kneecap or the patella, and you see the attachment site. And in cases of more advanced patellar tendonitis, that black tendon tends to take on a gray or whitish appearance in a very localized area, and almost looks a little thicker than the rest of the tendon in that area. And sometimes when, even when you look at it, and I know the radiologists frequently read it that way, they'll read it as a partial patellar tendon tear, which it probably isn't. It's just that the appearance of the fluid in the tendon, the whiteness of the tendon, gives it the appearance that it looks like it might be pulling away from the kneecap. So that's really what I look for.
Absolutely. And Dr. Bechler, are there any other treatment options that you might consider? So let's say, as we talked about, the patient has really been refractory to conservative treatment. Now they have this MRI that clearly shows that they have some significant patellar tendinopathy. Are there any other kind of conservative treatments or non-surgical approaches that you would consider before trying more aggressive options?
So I think there certainly has been some studies that show that bracing may alleviate some of the symptoms while not changing the process, but may make it feel better. Some patients, I would say maybe 40%, feel a little bit better if they use one of those patella tendon straps that you see go straight around their patella tendon, called the Chopat strap. But I think that's case by case, and it does to some patients make it feel better, although we know it's not changing the process. I think as far as additional treatment, certainly we cannot do cortisone injections into the tendon, because that weakens the tendon tissue and predisposes the patient for rupture. So we have to stay away from cortisone. Some of these new biologics that have come onto the market recently, such as PRP injection, which stands for platelet-rich plasma injections, or these other more esoteric ones, such as stem cell and stuff, are being offered in the community to try to treat this type of a problem. I think our practice is more mainstream and would, offer perhaps a PRP injection to an athlete who had had this for, let's say, greater than 6 or 9 months and may be affected with their participation as a high-level athlete. What do you think, Dr. Gatt?
Well, so a couple of things. As far as, one of the things I like to try to, as Dr. Bechler mentioned, you can't inject the patellar tendon with cortisone because it actually risks rupturing the tendon. So that's something you would never prescribe. But I do oftentimes on my physical therapy prescription write for something called phonophoresis or iontophoresis. And that's a way of putting cortisone on the skin and then delivering it to the tendon via an ultrasound probe or little electrodes. And that can be pretty effective. It's been shown, to be helpful in the literature. It's plus minus, but that doesn't risk rupture. So that's a modality that I like to use. Again, in the recalcitrant cases, the cases that don't respond to standard treatment. I do like PRP injections in the cases that are been present for 6 or 9 months and haven't responded to physical therapy. And I've had good success with it, but I think the success is that the patients are carefully selected. We don't use it on everybody because, number one, insurance doesn't pay for it. The scientific evidence is still not definitive that PRP works, but certainly it's being used a lot. But I think it has to be used appropriately, and you have to be honest with patients and say, look, we've tried everything. Nothing seems to be working. This is an option that we have. The evidence is starting to look more and more like it's going to be a treatment that we use in the future. But for right now, now this is something good to try. But again, unfortunately, they do pay out of pocket for it.
I agree. And both of you had great points. Foremost, that cortisone injections are not indicated for this kind of condition and can lead to rupture of the tendon, causing a lot of complication. And a lot of the other injections that you mentioned are somewhat still investigational, although I think that some of the studies do show some low-level benefit here and there, including for PRP as well as cell-based therapies. So I guess the jury's still out and we'll have to see. But as you mentioned, Dr. Gatt, I think that carefully selecting your patients might increase your success rate with these recalcitrant type of cases. Dr. Bechler, just wondering about surgical options. So let's say nothing works and you've tried these different modalities and you've tried a onslaught of injections and nothing seems to help the patient. And we have athletes here that really want to get back on the field. Are there anything more, is there anything more aggressive that we might be able to try?
So there is, a surgical alternative to the very chronic, severely affected individual who has this, jumper's knee, patellar tendonitis. But I'd have to say it's extremely, extremely rare that we get to this point where we need to do anything surgical. Because, it's such an unusual situation to be in, there's never been really a series or a study that showed, 100 patients who went to surgery and a certain type of surgery that worked for them. So every surgeon has up their sleeve a way to address this particular case that has worked for them in the unusual case that you have to proceed. So, if you see 100 patients with patellar tendonitis, you may not even operate on one. So that's how unusual it is. Yet when you get the one who's a college athlete who can't jump and can't play, it is good to have a trick up your sleeve, so to speak, to treat it with surgery. Surgery typically requires a long-standing period of immobilization and decreased activity afterwards of several months, because what we're doing in the surgery, no matter which way we do the procedure, is you're excising the tendon that has become inflamed and chronically irritated and stimulating the body to now form, good, healthy tendon. And the way you do that is to excise it surgically and then rest the knee so the body can now form better or less irritated and inflamed tendon. So that's, I don't know, Charlie, what kind of surgery do you use for this?
Yeah, so when I do surgery for this, and as Dr. Bechler said, it's extremely uncommon, but it's number one, I describe it to patients. I say, look, patellar tendonitis is kind of a low-grade, smoldering inflammatory response that won't go away. So what we're going to do is we're going to make it a high-grade inflammatory response, and that's what surgery does. So I'll, find, again, that's why number one, the examination is important and the MRI is important to localize the area of tendinopathy. So I'll make an incision over that area and size like a little sliver of the tendon, because it, generally looks pretty healthy, to tell you the truth, when you get in. Sometimes you'll see some chronic changes in the tissue, but it doesn't look that bad. And then what I like to do is right where I've excised the tendon, I'll actually drill a hole up into the kneecap, into the marrow cavity of the kneecap, because as Dr. Beiro talked about, cell-based therapies, your marrow is full of cell-based therapy. So by just taking a drill and drilling up into the kneecap, marrow leaks into that site. So number one, we're getting some marrow elements into the area of tendinopathy. And again, I'm creating that high-grade inflammatory response, which I think leads to healing. So it's a pretty simple operation. It doesn't take long to do. But as Dr. Bechler said, it requires an extended period of rest. After surgery, I'll put somebody in a knee immobilizer, which is a brace that holds their legs straight, and I'll make them walk in the knee immobilizer probably 4 weeks after surgery. They can do some straight leg raises to activate their quad, but I'll limit their knee flexion for a little while just to let the healing process kick in, and then then start being a little bit more aggressive in the rehab. But you're probably looking at more than 2 months before they can even think about getting back to sports, because if you push it too early, you're just going to restart the whole process all over again. So once they commit to surgery, it's it's a long time before they're back on the field, I think, for such a little operation.
Absolutely. And that's a great technique, by the way. I think you're giving the patient almost double treatment by debriding as well as exposing that area to the marrow elements to help the healing process. So with that said, I think there are surgical options for these recalcitrant cases. Again, they're not very commonly indicated. These surgical options can range from mini open or small open procedures to arthroscopic procedures, even to ultrasound guided percutaneous tenotomy. But as Dr. Bechler mentioned, there's really not a lot of studies that show one is better than the other, and that it's rarely indicated for these patients. That said, when can patients go back to play? When can they return to sports, let's say after non-operative treatment? Dr. Bechler, will defer to you.
So if they're not having surgery, I let them participate, as long as their pain is under control and it doesn't affect their ability to function at the level that they want to function at. So that being said, I say, you have patellar tendonitis. It's a benign condition. And as long as you can keep it under control, then you can play with it. Once it starts to affect your ability to participate at the level that you want to be, and it functionally impairs you, you're not as good as you want to be, then you need to take some time off. So it's more of a management decision as far as participation, as opposed to you're out and then you're in. It's something that you can manage as you continue through the season, understanding what your priorities are as an athlete.
Absolutely. So fair to say this is a somewhat chronic condition. As you mentioned, it's managed with all of these different modalities. And Dr. Gatt, I know you mentioned before about returning to play after a surgery. How long would you let athletes recover for, and when would you let them go back?
I think it's probably a minimum of 2 months, to tell you the truth. Maybe even, it depends on how they're responding to the surgical treatment. I mean, I don't want to push them back if they're still having some pain. Again, we don't know how quickly the healing process is going to occur with, whatever procedure of choice you choose.
Well, definitely, that was a very good summary of what's going on. Doctors Gatt and Bechler, do you have any other comments on patellar tendinopathy on jumper's knee?
I think, one thing I wanted to just brush up, and Dr. Bechler was mentioning about letting people go back and play. What athletes are concerned about, or what their parents are concerned about, is, well, if I have patellar tendonitis, am I going to rupture my patellar tendon? And the truth of the matter is, patellar tendon ruptures don't occur in symptomatic patients. Like, it tends to be, number one, a little bit older people, but almost every rupture I've ever seen has occurred in someone who has had no prior symptoms. And that's also what the scientific evidence shows us, is that, symptomatic individuals don't rupture and asymptomatic individuals do. So I tell them, if you have patellar tendonitis, don't be so worried that you're going to rupture your patellar tendon, because the likelihood of that happening is excessively low. So sometimes when they get that kind of vote of confidence that they're going to be able to play, and they don't have to, the same thing happens with Achilles tendonitis, right? Everyone asks, like, well, I don't want to rupture my Achilles tendon, but they're not going to rupture it. So that gives them the confidence to play through a little bit of pain. But I think, again, what Dr. Bechler said is really important. Once it affects their performance and they're not performing at their desired level, then that means that it's time to stop. So those are two really, I think, important take-home points that I try to drive home in the office.
Absolutely. Well, for everyone at home, just wanted to say that if you're having any kinds of symptoms that look like patellar tendinopathy or jumper's knee, please reach out to us at uoanj.com. Thank you, Dr. Bechler and Dr. Gatt, for joining us tonight and discussing patellar tendinopathy or jumper's knee.
Thanks, Chris.
Thanks, Chris. Have a good night.
You too. Have a great evening.